glad you've joined us today, especially in this weather and fire alarms and other things if you've been on other parts of campus. Each participant with us last summer was asked to craft a vocational biography, and here's a bit of Aaron's. Aaron Franzen's work in sociology is more or less a guided chain of paths of least resistance. He enjoyed chemistry the most in high school, and so naturally, he went to college looking to be a chemist, realizing that liking a subject is different than living a profession. He decided to change to sociology and philosophy. After college, Aaron did a master's in historical theology and then a master's and PhD in sociology. He attended grad school because he became fascinated with the idea that different individuals experience and interpret the same realities in different ways, as a shaper with different ways patterned by their contextual and social attachments. Because religion can be a strong identity shaper with more or less distinct communal attachments, Aaron went on to study sociology of religion and later the connection between medicine and religion. Physicians and doctors are interesting to Aaron, well, because he's married to one, and because physicians have personal beliefs and professional beliefs that are not always examined in conversation with one another. Putting different beliefs in conversation also relates directly to Aaron's interests in mentoring students. He sees his vocation in part as helping students clearly connect and construct coherent vocations. So please join me in welcoming Dr. Aaron Franzen.
All right, thanks for coming out again, everyone. So when I came here to interview at Hope, I had a long conversation with President Knapp. It was like over 2 hours or something like that. And we had a conversation about physicians and beliefs and religious and spiritual interactions with patients and these kinds of things. And I remember at one point he pivoted the conversation to academics and beliefs in our work as professors. And I remember thinking internally and likely externally, because if you know me, I have a terrible filter, that I'd never thought about my work within medicine and how it could relate to my own work as an academic. So now this isn't to say that I had never thought about this before, because I had, but it also goes to show how easily we can silo not only our disciplines, but also our own thoughts and the application of different areas of our own lives. So I found the Summer Continuum Scholars program to be valuable. It's a good dedicated time for us to reflect on the work that we do. So for faculty out there that haven't done it yet, you should. But a few semesters ago, I got a review in one of my teaching evaluations that in some ways kind of sums up, I think, some misperceptions about what sociology is that maybe we should clear up first. And I'm also still dealing with it emotionally probably a little bit too. But as the student said, the review said, it was all just common sense. Just common sense. And the problem is that I, as a sociologist, I don't know how to make sense of that. I don't know how to understand that comment. If it's true that our perceptions and our ability to make distinctions between things and value things and have goals and all these different things are to some degree dependent on our social exposure, so the people that we're around, then perceiving some social piece of knowledge as common sense and stopping there is just sociologically lazy. And so common sense is patterned, it's predictable, sure, but common it is not. And that is sensation, however, the sensation that something feels common to us is really interesting sociologically. So Peter Berger, he once wrote that, quote, the sociologist tries to see what is there, and later he goes on to say, the fascination of sociology lies in the fact that this perspective makes us see in new light the very world in which we have lived all of our lives. And so we as sociologists, we make sense of people, we make sense of interactions, we make sense of the context in which those things happen and they take place. And we are concerned with understanding society in a disciplined way. We do this proceeding scientifically. We do this with the aid of a deep toolbox of methods that spans all the way from qualitative tools fairly complex quantitative tools, which a lot of American sociology tends to be dominated by a little bit. One defining feature of sociology is our tinkering with and fine-tuning theory. It helps us artificially isolate causal mechanisms to make sense of the social world around us. And so theory helps us to interpret and make sense of facts, because all facts don't have any inherent meaning and are necessarily meaningless apart from the interpretive tools that we bring to make sense of those facts. So, in this way, and this is central for the rest of what I'll say today, all things are nothing to us apart from the tools we have to recognize them as a thing in particular. So to say that again, all things are nothing to us apart from the tools we have to recognize them as a particular thing. So we, in some ways, in some little ways, we make things things. So a few years ago, my wife and I, we took a trip to Costa Rica, and this is the backyard of a farmhouse that we were staying when we were in the Monteverde cloud forest. And when we were there, I remember we went on a guided hike with a guy, and he was leading us through the forest and showing us, you know, things you look at in the forest. And I remember there just being a cacophony of noise, just a bunch of background noise as we walked along. So as we go along, there's you've got the wind, and you've got rain, there's insects, and there's birds, and everything else. But birds were the most interesting part. The guy he knew his birds. He was kind of a birder. And so as we're walking along, he at one point points out a bird call that's going on in the background, and he tells us that it came from the resplendent quetzal, which is a fairly uncommon bird that you can only find in that area of Costa Rica. It's a gorgeous bird. And so after we hear the noise, we're able to find the bird and we see it. But the thing that's interesting about this to me is after learning what the call was, suddenly the cacophony of sound was less meaningless to me. Suddenly I was able to pick something out of it that I was unable to pick out before he pointed it out to us. And so again, all things are only things to us when we can distinguish them as that thing in particular, a bird. So, over time, one's unique history, experiences, and socialization create a somewhat unique, although necessarily shared, taken for granted sensation of the world around us. The creation and consolidation of worldviews that lays the groundwork for our goals and our values, dispositions, preferences, actions, and even our voting behaviors, these things have long been of interest to me. And I conceptualize this as our identity, who we are, and how this is shaped, why it matters, or even how this matters, like our identity. And so within sociology, my initial home was in the sociology of religion, because religion tends to be a pretty comparatively powerful identity shaper. It tends to answer life-centering questions like what reality is and what our place within reality ought to be. And so my first project and publication in grad school focused on what effect reading the Bible had on the Bible reader. So as it turns out, the more you read the Bible, the more, on average, you become more politically liberal. But this is interesting because this depends first whether or not on whether or not the reader self-identifies as a biblical literalist. And this is because that has a lot to do with how can you talk about the Bible and what the contents are. So then it shapes what you find when you actually go read the Bible. But additional projects during this time were showing how criminal propensity, spiritual but not religious individuals had differing criminal propensity than other people, other religious individuals, how geographic religious concentration and women's propensity to work outside the home were related to each other, sociological explanation of biblical literalist identity, and different communal dimensions for whether someone goes to college or not. So, later in grad school, I began to focus more on health and medicine, most often as they relate back to religion. And some of this work focused on social determinants of health. So this is an example of one paper. This is latent variable model where we were tying on the left side there, this is different genres of TV and whether or not people felt like their religious beliefs were offended by that genre, predicting people's mental health, and these were indicated by DSM criteria, so this is like obsessive compulsive disorder and things like that, and how that was moderated by the individual's religiosity. So did that kind of stuff, but my main area of research is on how beliefs and values of physicians change through time and how those beliefs and values influence their practice of medicine and their patient interactions. So in other words, do physicians' personal beliefs relate to and overlap with their professional beliefs and values in their identity? This is possibly a more important question than may initially be apparent. So if one of the ways that we make sense of who we are as individuals is by what we do, so mother, father, sister, brother, student, professor, these are all different roles that we play. But what happens when you can no longer carry out the actions associated with those roles? So am I still a father if I'm stuck in bed ill for a month? Does my identity shift? Am I still the father at that point? So on the one hand, you say, of course you're still the father because you have children. But again, it may not always feel like that to the person who's ill. If you are the ill individual and you're unable to do things that you normally would do, it changes how you feel about yourself. So we necessarily attach actions to our roles, and you might not be able to do them anymore. So it's for this reason we tend to think of illness or sickness as a temporary role that you can kind of take on and kind of excuses you socially from your usual expectations. So most of us, we've probably gotten this email from a student in class, I'm sick, I won't be in class today. But it's not like at that point you stop perceiving them as a student. If students go to class but they're sick and don't come to class, how is it we still perceive them as a student when they're not in class? So we have to kind of make sense of identity in the context of all this. But what happens when the illness doesn't completely go away? Or what happens when the sick individual is unable to ever do the same things they used to do before they became ill or before they had an accident? Are they still the same person? On some level, we have to reconstruct our perceptions of who we are in the context of the illness or the accident post-injury. And so, while at times this may be dramatic and other times not, illness and medicine more broadly is always connected back to identity, interpretation through time. Who we are through time. So now if a patient is religious and they make sense of their reality and their self in the context of their religious beliefs, but these religious beliefs are not a part of their medical interactions with their physicians or other medical providers, what happens to that identity that changes as a result of being ill? If you make sense of yourself in the context of religion, and that changes as you're ill, what happens if it's not a part of reconstructing your identity in medicine? We know that patients desire to have these kinds of conversations with their physicians. There's a wide range, but it's anywhere from 20 to 60% of patients desire their physicians to talk to them about this kind of stuff. Many physicians also acknowledge that these are important things to talk to the patients about. But we also know that it happens very rarely. Not very often is there these kinds of conversations. So we have patients who desire it, physicians who acknowledge that it's important, but it rarely happens. So we have to try to make sense of these kinds of things. We also know that the distribution of physicians who do include religious or spiritual content in their interaction with patients is not randomly distributed. So some have these conversations a lot more often than others. And any given physician will be more likely to do something if they perceive that it's relevant to their practice of medicine. So if it's relevant to your job, you're more likely to actually do it in your job. So not all physicians think that religion and spirituality has an influence on patient health. Perceived relevance has to do with whether or not those tools are at the ready or not. If you're personally religious, you probably have the tools more readily to make sense of why someone else might want to talk about that stuff. So again, remember that things are only things when we're first able to recognize them as something in particular. So what is medical or not is the same. If a physician can only include or be on the lookout for the need to include religion and spirituality when they first perceive it to be medically relevant, which tends to be related back to their own religious beliefs and background. So this is from a paper a couple years ago. Along the bottom, the x-axis is increasing from the physician. These are all physicians. Their perception that religion influences the health outcomes of their patients. And you can see that here on the end of very much, these tend to be religious and spiritual, and mostly spiritual and not religious physicians. Whereas on the other end, I think there's very little influence. These tend to be non-religious physicians. So again, the personal biography of the physician is changing the perceived relevance of something in the clinic. So thinking that patient health outcomes are influenced by religion and spirituality pretty effectively predicts the inclusion of it in clinical settings. But not all physicians, as you could probably guess, equally think that religion matters for patient health. So physicians who personally have a more religious and spiritual orientation are more likely to have made this connection between religion and health. So on the left, we have their own orientation predicting the belief that it matters for patients, which in turn predicts how often they actually talk to patients about it. And this is the dominant pathway through thinking that it matters for patient health. So in other words, those physicians who are personally more religious and spiritual are more prepared to recognize it as more medically relevant. But this is still somewhat complicated because we assume that patient specificity matters, right? So interactions with physicians depends to some degree on who the patient personally is. And so as such, you would think that in geographic locations where there's more patients that are religious, more religious patient population, you would think that there would also be more frequent religious and spiritual conversations. In other words, based on assumptions of patient-centered care, where medical care is somewhat unique depending on who the specific patient is, we would think that there would be at least a marginal increase in the kinds of conversations in those religious counties. This is not actually the case, though. There is no influence of the patient population on how often these conversations are happening. So again, the religious spiritual orientation of the physician dominates how often it's actually included in patient care, not who the patient actually is. So as I was working through a current project with a student, we came to realize that so far all of this work, including the stuff that I have done, tries to make sense of the inclusion of spirituality and religiosity in clinical contexts, that it's all coming from the perspective of patients. Why it helps, when it should happen, who provides it, who does not, and so on. It's all generally from the perspective of patients. But if physicians do things within the clinic that they think they should be doing, then on some level it would help us to know a little bit more about what physicians think a good doctor is like and what they should do. So we heard from physicians all about the importance mainly of relational connections with patients. They all agree that technical stuff is important, but the additional thing that makes a doctor good is a relational connection with them. So this was often informed by their perceptions of service orientation, perceptions of persons, and these kinds of things. And those values, how they see people and having a service orientation, almost universally was informed by their religious beliefs. And so it occurred to us as we were going through this that these were all stories about how physicians' religious beliefs helped them make sense of their work and brought meaning to it. So how they made sense of their job as doctors. And so as the argument goes, this matters for, we tend to say that this matters for patients and patient care. So let's see when it's provided. But again, this implies that we know something about what physicians think that they should be doing in the clinic. And just because some people want something, or because some dimension of our lives would be helpful in like a medical kind of a context, doesn't mean that all physicians know that or even agree. So we kind of need to know something about physicians. And trying to make sense of patient-centered care, we have ironically ended up overlooking the physician. We, rightfully so, we're quick to highlight the personhood of patients, but sometimes we forget that the physician is also a person in the process of doing so. So, What we really need to do is to understand how patients make sense of their lives, especially in this context with religion. And then we need to also understand how physicians make sense of their self and their profession, like their work, what they should be doing. And then after this, begin to make a little bit more sense of how those two horizons of meaning meet in the clinic, and make sense of that. So this is kind of where my work is at right now. But I'd like to shift the conversation here a little bit, because so far I've mainly been talking about faith and religion and how me and my work as a sociologist looks. But is all of this about more than me and my work? Right? Is faith and sociology about more than my idiosyncratic approach to my particular interest? So I want to propose 2 points. First is that maybe not all, but at least some sociologists have to be Christian. And second, that all Christians should be sociologists. So while there are different ways to lay a foundation here for this, I will make use of one of the original micro-level social theorists, George Herbert Mead, which students are familiar with. So he thought that humans are unique in their ability to think about multiple meanings or interpretations for any given situation. So what is going on? What does it mean? How should we make sense of it? So for example, maybe your neighbor just put a political sign out in their front yard. What does the sudden appearance of that sign mean? How do you make sense of it? Maybe they just want you to be aware that somebody's on the ballot. Or maybe they just want you to know that they think you specifically are wrong about something. Your neighbors after all. Or maybe they want you to know that you and them could be friends, or maybe they're trying to make a statement about gun control. Or maybe it's all of these things, or maybe it's none of these things. But the point is that we attach a certain, we attach a plurality of symbolic meanings to any given situation. Or I'll put this another way, a plurality of symbols are the middleman, so to speak, between us and any given situation. The sign in the yard in of itself doesn't mean anything apart from the symbolic interpretation of the sign. So now we are able to hold multiple symbolic meanings in our mind at any given time, and we then in our mind extrapolate the outcome of our future actions based upon what each of those interpretations are. So of the political sign in your neighbor's front yard, you think about what it might mean and how you're going to respond to your neighbor when you talk to him. And we try and practice in our head what the most successful outcome will be, and then that's how you behave. And so we select the best possible outcome of our actions flowing from a selected interpretation of the sign in our mind, and you act. Over time, this by and large can become fairly automatic. You don't think about a lot of these things after you've been around for a while, and there's some key caveats to that. But the issue with this is that just like any language, symbols and the ability to understand them depends on exposure to them. You can't understand things like language and symbols without being exposed to them. So this means that you can't know what something means apart from being around other people that also think or know something. It can't be the mere exposure. So just because I see the tattoo you have on your arm every day for a year doesn't necessarily mean I know what that tattoo means, right? It requires, on some level, some kind of interaction between you and I. So this brings me back to my first point. Maybe not all, but at least some sociologists must be Christian. So if one, nothing is a thing apart from our recognition of it as that in particular, and two, our ability to make sense of any given situation is dependent on successfully attaching interpretive symbols to it, and three, the creation and maintenance of this interpretable ability is communally or exposure dependent, then we're better off as a field, sociology, with practitioners from many different backgrounds. That is, we need a plurality of views within the scientific community for it to be healthy in terms of interpreting the social reality we are trying to make sense of. Symbols attached to and make sense of things or situations, it's created in specific communities. So various backgrounds from various communities contributing to the field would be best so as to not overlook something that's right there in front of us. So even though what I do in terms of methodology and the process does not change because of the fact that I'm a Christian, it is possible, if not on some level even maybe likely, that what phenomena I look at and what I see when I look at it is different. At least some of us need to be Christian in sociology. Second point. All Christians should be sociologists. Now, I don't mean that we all need to be sociology majors or academics per se, so bear with me on this for just a moment. So, as I've said, the ability to make sense of any given situation depends on our ability to recognize it as a thing in particular. To connect meaningful symbolic interpretation or interpretations in the plural to a specific situation depends on learning to see it as something specifically. So a sign in someone's front yard doesn't mean anything if you can't read, right? Or if you don't know the name on the sign. Or if you're new to the country and don't know anything about Democrats or Republicans. Or anything else, fill in the blank. We learn stuff from those around us, from those we are exposed to. So our group membership and exposures on some level has to matter. This becomes even more interesting when you take into account the fact that the situations, as I've been using it, doesn't just mean stuff like making sense of random signs in your neighbor's yards. It also makes sense of making sense of who people are. It's not just situations, especially those who are not actually our physical neighbor. This becomes interesting because what we think of people can be, and maybe even likely is, independent of who they actually are. But again, we connect our interpretation to the situation and select our future actions in accordance with that interpretation. So in other words, we interact with people based on what we think of them or who we think they are, not who they actually are. It's who we perceive them to be. But we need to be able to make sense of and connect with people that are different from ourselves. On the one hand, this could mean that we just need to go through life with a series of experiences that are kind of like a culture shock that jar us out of our stable but depersonalized expectations of other people. Or alternatively, it could behoove us to acquire a more effective toolbox to help us do this. This is the place of sociology. Now, I don't mean that everyone, again, has to be a sociology major or something like that, but I do mean that we must be able to make sense of how we come to perceive the world around us in a certain way, and through that ability, make as heartfelt an attempt as possible to take on the mindset or the worldview of other people. If we can, as C. Wright Mills said, place biographies within a historically specific context, then we have taken on the sociological imagination. This requires knowing the self, but knowing yourself in a somewhat systematic way. Some way so that you can see the construction of other people through the construction of the self. So, why does this matter for us as Christians? We're called to love the neighbor second only to loving God. This then leads us to ask the same classic follow-up question that the expert in the law asked Jesus in Luke 10:29. And who is my neighbor? We tend to focus in this on the who. Who is my neighbor? Which obviously is key, and we tend to focus and direct our love towards people that are within our own group because we recognize them as our neighbor. They're easy to recognize. They're within your own group. But we have to move beyond that political sign in our neighbor's front yard, even if you're right about the sign. And we have to recognize that you're called to love them just the same. And love them as Christ does, which is actually a pretty high calling if you think about it, because his love for us didn't have a limit. Right? His love for us led to the literal loss of his own self in death. So it's a high calling. But it's more than just about seeing people, the who in here, because what it means to love them somewhat depends on what we see when we look at them. So the who is my neighbor may be the more important part. This is where sociology can really help us. We must make sense of people. We must make sense of groups, identities, especially when these are in conflict with our own self. This doesn't mean that we have to agree, but it does mean that we must be able to relate to them, to connect with them, to heal, to love, and to live. Thank you.
We have plenty of time for questions for Dr. Franz. Who would like to go first? Well, I have things waiting, and I can also call on.
How widely known is it in the medical community, in medical schools, some of your research? Are there programs afoot with people who are acknowledging this disconnect that we sort of point out between physicians' knowledge or lack thereof, ignorance of the role of religious beliefs in terms of their perception of what it means to give good medical care to the patient?
Yeah, this has really been changing over time. I mean, the field of religion and health has massively grown since like the maybe 80s or so. And so now it's to the point where upwards of 90 to 95-ish% of med schools have some part of their curriculum is about religion and spirituality. But again, this isn't always full classes. This could be like a day in maybe ethics or something like that. So the recognition is definitely there, but I mean the bigger issue is there's just a lot of conflicting desires and pressures in medicine, and we only have a very limited amount of time. And so if it had to come down to like knowing someone's blood pressure or knowing what religion they were, the blood pressure would win out. And so our interest and investment in patient-centered care is made challenging by conflicting desires in medicine. So it's there for sure, but it's hard to do it in practice in reality. But I mean, if it's important enough, this is why the rates of physicians having these conversations with patients in the context of like oncology is significantly different than other types of medicine. So the severity and the context of the medical problem, it changes a lot of how this stuff works.
I couldn't help but think as you were giving the examples about patients and physicians and thinking about religiously oriented questions, about student-centered advising in our Hope College context, and whether or not we talk about questions of faith and spiritual identity, having just come out of advising week, and some of those same, tensions in terms of, do we talk about your classes for next semester and the things you need to get to graduation, or do we talk about some of these bigger questions? I don't know if you see any insight from your work that we could apply. That's kind of a big, broad question.
Yeah, no, it's a good question. It's like the conversation with President Mack. It's like, how do we actually apply this stuff?
Right.
Yeah.
Well, you did get your job, so it must
Yeah,
have been
it must have been at least not a troubling conversation. Yeah, I mean the research on like vocation and calling, there's a huge overlap on. So if it's true that calling and vocation requires people to situate what they do in a broader context of meaning, then these conversations seem really necessary. And the rates of burnout and different potentially problematic things when people go out into their professions are a lot lower when people have a calling or perceived vocation. So yeah, I mean, on some level, I think the answer is yes. We should have those conversations, but at the same time, I mean, as you were saying that, I was like thinking about my advising group. Right?
Yeah. Me too.
I gave my students 15-minute slots,
right.
And you know, if you've got a hard schedule to figure out, then we're not talking about your religiosity. So in the same way that there are conflicting things going on in medical context. I mean, we have it too. But again, I mean, everything that we do theoretically we find valuable. So if it was valuable, then we would find a way to make that happen, which usually in our reality is tied to money when you talk about professions, right? So, you know, you gotta incentivize things on some level sometimes. Because we all love people, but I also have a family, you know, and I like to go do stuff.
Right.
So yeah, I think yes.
I apologize in advance for how this metaphor is going to break down and be offensive, but maybe in the same way that you said issues around religion become more important with oncology, I'm wondering in the advising situation,
Right.
that in certain situations, as students get closer to the existential doom of graduation, no offense, that might be situations where religion becomes even
Yeah.
more salient.
Yeah, and I was thinking that too as you were talking. I've had those conversations with students, but I don't have them with all students.
Right. There's a person.
Yeah. So I'd like to think maybe unlike the physicians, we're better at connecting with the people we're talking to. Not to say that they don't, but again, I think their pressures are more significant than ours. So maybe we're better at actually feeling out that existential angst.
Yeah, I think I want to see the graph where the existential doom category is. Others.
You talk about how, you know, you need tools to recognize things as things.
Yeah.
So what are some tools that Christians can use to become more sociologists in their day-to-day life?
Yeah, I mean, this is really challenging on some level because the way that, by and large, we think about things on purpose very little throughout our daily life, right? Like how you talk to people, or like if you meet some person you've never met before, you're walking down the street and there's people walking towards you, like how you react. Like, by and large, we don't tend to cognitively think about a lot of this stuff. And so that's why I said the culture shock thing, because it's really easy to have assumptions about people until they break down. And so, yeah, I think you have to develop a certain level of empathy where you can imagine the possible world of others instead of the world that you think that they have, which I recognize is kind of a known answer for you. Maybe practice of you know, connecting with people that are really not like yourself is a productive way to start.
Thank you.
Was education one of those tools? Could be.
Yeah, I mean, but it probably depends on what kind of education you're talking about. Like, I'm skeptical that just education generally makes people better at seeing people as people. But I'm a sociologist. Yeah, so it probably depends on what the because you could imagine a situation where in the educational context you're exposed to ideas that you kind of already believe, and you go to school with a whole bunch of people that look like you, and they're from similar backgrounds, and you know, whatever. So there's probably more and less productive educational contexts, barring the content itself, which is maybe a whole other layer of complexity for that.
Andy.
So, given all of the time pressures that physicians have and professors have and other Christians have, but yet we have this desire to have these kinds of conversations, what's the solution to this problem? How do we sort of open the door to these conversations between faith and disease, or faith and just, you know, becoming a better student, or whatever it might be? How do we sort of advance? Do you have all the solutions? Do you have all the answers?
Yeah, we gotta wait for those publications.
If I could tag on it, isn't that some of the point of your work has been, and I'm thinking about the discussions you had in training positions, in terms of helping them to see that those discussions, patients perceive those discussions as being important. And the question then becomes, will physicians, you know, embrace the consideration of training with that?
Yeah, I mean, I think at least when it comes to physicians, I think a lot of it comes with along with how we socialize physicians. Because again, you could as a patient tell your physician, look, it's super important to me that we talk about golf every time we're together. And, you know, the likely response is the physician's like, yeah, I don't really see how that really matters for your cholesterol at all, except for like maybe time to relax, but you can do that with taking naps too. So, just because patients think something's important doesn't necessarily mean it appears to physicians as relevant to what they're doing. So I think going back to maybe my overall point at the end is if we individually and personally think these things are important to get to know people, especially those that we don't really know very well, then we kind of just need to do it. You know, I mean, we can think of excuses all day long, but at the end of the day, like, we all have competing pressures. We all have multiple classes. We all have lots of grading to do. We all have publishing to do. But we still do things. And so the things we do tend to be also the things that we find is more important for our daily lives. So again, if we find it important to love our neighbor, then on some level we'll do it. And so maybe the frequency at which we seek those interactions out probably also says something what we think about neighbors.
Aaron, your discussion about the doctor-patient relationship, I'm thinking of some of the classical work that's been done on that, Kelvin. And, you know, a lot of that older stuff always argued that that relationship had to be asymmetrical in way of power. That the physician can't appear to be wishy-washy or not know. And so, getting to who initiates these discussions about faith, and it's really the physician that does it. How do we give patients more agency in entering into these discussions that, hey, I need to know more about this, and I want to talk about this?
Yeah, that's kind of complicated because it's, first of all, it's much different now than it used to be. So it used to, you know, medical care used to be strongly paternalistically driven, where you've got the authoritative male figure that tells you how you should do your diet and exercising and sleep and all these different kinds of things. And so those relationships have changed. But there's been some work that has shown that patients that don't have the right kind of medical cultural capital, where they like know something about medicine and know how to talk to their doctor about it, are basically ignored to some degree. So like if a patient can't effectively communicate with someone in power like a physician, then they probably won't be listened to very much. The conversation, there will be more time spent by the doctor talking and not the patient talking. The physician won't ask or allow the patient to ask as many questions. And they might even say something specific, like I've heard this from physicians that say, I give my patients one question, right? And so it requires a certain level of knowledge and capital on the part of the patient. But if the patient becomes too pushy, this will be destructive for the relationship too. So we need, like, the rate of heart failure patients that go back to the hospital 6 months after being discharged is in the 50 to 60% range. And a lot of the explanation for that, they say, is because of non-adherence. So they leave and they don't take their pills, or they don't eat right, or they don't, you know, exercise, or whatever the case might be. And a lot of the explanation for patients not adhering to recommendations is trust. And so if patients don't effectively trust their doctors, or if they're overly pushy and the doctor gets kind of short in response, it'll destroy a little bit more of that trust that's necessary. So the long answer to the long way to get there is it is changed historically. And I think we're educating physicians significantly differently than we did in the past, and that's mattering. But there's still a little bit of the power dynamics are not equal in the clinic, I'll just say that. And so when patients forcibly try and change that, it can actually become kind of destructive.
But we are also consumers of healthcare, right? I mean, we can go and seek out doctors who will listen and have these kinds of discussions.
That's true, although the research on patients selecting physicians is that's actually pretty rare. We're talking like low teens. And A, this is because we have pools of physicians you can select amongst, and maybe you've got 3, maybe you've got 5, maybe you've got 1 or 2, depending on where you live. And so you might not have a choice. But even then, if you have a doctor that you hate, it takes work to go find a new one, and people don't tend to do that. So you'll just stick with that doctor that you don't like, probably.
Others?
I kind of want to go back to the advising connection.
Yeah.
Because if we think about the doctor-patient relationship, that's the sort of thing we do for well checks and when necessary, right? And the well checks are deemed kind of necessary, perhaps. And I wonder if, in some ways, we think about advising in the same ways. We sort of like do it only when necessary. We confine it to advising week, and we make our available slots that are really like tight and trim, and we want it to be effective and efficient.
Totally.
So send an email, I'm talking about it as a prof here, that says to be prepared to make the best use of our available time, here's what you can do to prepare, right? So if we have the only as needed crisis advising week moment, are there things we can do to prepare for that equip students to have agency to come with the plans, but also to equip them to reflect on key questions?
Sure.
Where are you in your discernment process?
Yeah.
Are there questions we should talk about? How are you I'm just going,
for sure,
thinking here. But then my hope is that we would also see advising week as one bead on a string of beads, many points of connection. Maybe not 100 of them in a year, but more than one.
Right.
In order to situate the planning of courses within the larger planning of their time at Hope, within the larger planning of their time longitudinally,
Sure.
as they go forth with Hope into the world.
Yeah. Well, yeah, when you first started talking, what it made me think of is so usually in any given well check in like a clinic, you've got like a standard history and physical form even. Usually it's like a form where you just checklist things, and then it's like, oh, you have existential problems. Maybe we should deal with that in this meeting or whatever. And so at least that there could be some kind of a standard thing like that put in place. So then, if you knew you needed to, whether it would be helpful to touch base in those specific ways, then you could. But maybe it's also a little bit of a cultural thing. So like I noticed a big change when I came from Baylor to here, and I was first teaching. I was actually pretty astounded by the frequency at which students would bring things up from other classes.
Mm-hmm.
That never happened at Baylor. I don't remember it ever happening. And so there's already a cultural dimension, I think, at Hope built in with students, where they are making connections across classes and disciplines and through their years that doesn't seem to be happening, at least in some other places in my highly unscientific, past. And so I think there could be like a culture-wide thing where it's not like it's all on me to meet with my 30 or whatever different advisees 10 different times throughout the year or something like that. But that there's a way in which like we as faculty and staff talk and think about things that helps them make connections just on the fly. Right? Like when you just in passing mention something in class or something like that. So maybe those two things together where we communicate overtly to them that we're open to those conversations, and if we go past my 15-minute time slot, that we do stop it, but that next week when it's not advising week, we should set something up. That in combination with an organization-wide culture change, which actually I think is kind of there a little bit already. Yeah.
didn't know that you were going to get charged with figure out advising today, did you?
I know, that was.
Yeah, that was an
completely
unexpected social outcome.
Unforeseen.
Right. Anyone else? Yeah.
That's kind of a question comment, but it kind of puts together a couple questions.
Good.
Somebody had asked about kind of tools for how to become sociologists, and we've also been talking about advising. But what I actually have started to do, because nursing, we talk about health holistically, and I will say that spirituality is the one topic where students will brush back and say, I can't ask questions about spirituality.
Yeah.
That is personal, and I don't have any right to ask those questions. So that's they can talk about culture, they can talk about constipation, but they cannot talk about spirituality. But the kind of the response to that is that what I've actually recently started to do during my advising, or when I'm talking to students or doing feedback on my practicum, if I know that they have a half semester where they're a little bit lighter, because we have a lot of half semester classes, is I have been encouraging them to actually start to look at some of the emails that get sent about different cultural, events on campus where they will have exposure to interacting with students who are not like them. And I have actually really been trying to promote that as a way, because if they only hang around people who are just like them, they don't learn the skills to interact.
Right.
And I think that is one.
No, I think that's a great suggestion. Yeah, that is a super ironic thing about medicine, though. Like they'll talk about things that are very awkward in a normal conversation.
Anything.
Even religion's more awkward than constipation.
Well, Fritz, let's one more time thank Dr. Fritz.